Welcome again, everyone, to today's Schwartz Center Compassion Action webinar, Challenges and Best Practices in Protecting the Healthcare Environment in Today's Complex World. Thank you for joining us. I'm Angelina McCoy, Member Experience Manager here at the Schwartz Center. As many of you know, we are a Boston-based nonprofit organization established in 1995 to advance compassion in healthcare. Our vision at the Schwartz Center is that everyone who provides and receives healthcare experiences compassion. Thank you for joining us today as Bonnie Michelman, Jenn Goba, and Matt Thomas discuss protecting the healthcare environment. Before we do that, I'd like to share a few details about what you can expect. Please note that the program will last 60 minutes with a panel discussion for the first 40 minutes or so, followed by some time for questions. Please feel free to enter your questions in the Q&A pane throughout the discussion. I'd also like to acknowledge with gratitude that this Compassion in Action webinar series has been funded in part by a generous donation made in memory of Julian and Eunice Cohen. With that, I'll hand it over to Dr. Beth Lown, Associate Professor of Medicine at Harvard Medical School and Chief Medical Officer of the Schwartz Center for Compassionate Healthcare. I know she's excited to get this conversation started.
Thank you so much, Angelina, and thanks to all of you for joining us. This is a very, very important topic, very much in the news and very much of concern. So I'm very happy to introduce first Bonnie Michelman, CPP, CHPA, who has extensive leadership and security management experience across very diverse industries and national boundaries, and is currently the System Vice President for Police and Security for the Mass General Brigham system. Her security operations protect patients, visitors, staff, and the assets of 15 hospitals and hundreds of off-site facilities. So I'm very, very pleased to introduce Bonnie to you. I know that she's going to introduce the rest of her team and share some thoughts and the programs that they have put into place to really manage the protection of the healthcare environment in this very, very challenging world that we have. So Bonnie, welcome.
Thank you so much. It's a pleasure to be here, and good afternoon, everyone. We are very honored that you invited us to speak at this webinar. To say the least, what the work you do is incredible. We hope to be able to provide you a little bit of a glimpse of the world that we are trying to assist and help protect for Mass General Brigham, and I'll be using a lot of examples from Mass General Hospital, which is where we've spent a lot of our time. And it's a somber subject. There's no doubt about it. There's an article, I haven't read it yet, in the Globe today about workplace violence. I do a lot of work nationally on it. But I also think there's a lot of optimism in terms of the things that we've done to try to greatly diminish and mitigate conflict and violence and make people feel safe. So I'd like to start by going to our first slide. Keep going, please. Next slide, please. So I'm not going to spend any time on this, but any given day, if you turn on the TV or you listen to the radio or you get on social media, you're going to see a lot about assaults around the country. I've been doing this work for many decades, and I can tell you it's far worse than it ever was in many ways. And the number of people that are angry or impaired or are dysregulated is high, and healthcare is often the victim of that level of violence and conflict. And it's often not violence we're seeing, it's threats, it's stalking, it's bullying, it's intimidation, it's subtle threats, etc. And that's where we really spend a lot of time training our workers. Assaults do happen, but they're far less than all of the other things. Next slide, please. This is really important. These are some of the things that keep me up at night, shall we say. I feel like the role of my department and departments now, I recently got the promotion for the whole system. So we're going to be trying to universalize and synergize the work of our security and police departments throughout MGB. But we've been trying to keep people from being on that continuum where they're not aware or alert or educated about security. I call it complacency in the one end, to overreaction and fear. So examples of that are after the Boston Marathon bombing, after 9/11, after we had a stabbing at Mass General Hospital, after Brigham had a shooting there. People go from complacency to overreaction and fear. And that fear is justified, it's real. But what's very important is that we keep people in the middle of that continuum, educated, aware, alert, empowered, and that's where people need to be. We've seen an increase in volatile behavior. Interestingly enough, healthcare has the lowest amount of active shooters of any industry in the country. I want to repeat that because it's important, the lowest amount. It is not an industry that's targeted by active shooters. That doesn't mean there aren't any, but they're rare. And when they do happen, they are not in emergency departments, as people might suspect. They're often in inpatient units where it's a targeted, sometimes a mercy killing, or in an ambulatory care facility. We see injuries from assaults or attempted assaults are very low, which is a good thing in our system. Verbal abuse and threats are significant, and they vastly affect staff. I remember a couple of years ago that we didn't have lost work days for the most part, except for two pretty significant ones from staff that had just been targeted by verbal abuse by a patient for a long period of time. We now look at populations that may be committing violence or conflict, but unintentionally. And there's a lot of that. And we try to discern intentional versus unintentional violence. Unintentional being from people with dementia or Alzheimer's, from people coming out of anesthesia, from people that have head injuries, et cetera, et cetera. That doesn't mean the consequences of their actions are any less problematic for people that they victimize, but it does mean that we may look at interventions or medical care plans in a very different way. We do see more contraband, particularly drug contraband and weapons being brought into healthcare settings. Some hospitals across the country, not many yet, but some have gone with metal detectors. Some have actually taken metal detectors out. They require a large amount of staff. They change the course of a culture of a hospital. They don't always work to detect a weapon. And they can be what I call security theater, where it looks like there's something that's being done when it may not be done. With, as you know, when you open a bag when you're in a concert or a sporting event and they don't even really look in it. There is some increased use of substances and alcohol since the pandemic. We know there's a great deal of fentanyl on the street. We know there's less ability to care for some of our substance use patients and patients with behavioral health issues because of the lack of psychiatric facilities and sometimes skilled nursing facilities, forensic facilities. That's not only in Massachusetts, it's across the country. But because of that, we do see longer lengths of stay. We see people escalate because they're not able to get perhaps into a facility that is more beneficial for their needs, et cetera. Visitor noncompliance can be problematic, a little bit easier to deal with. Really important, we're seeing a lot of the isms, I call them the isms, the hate and discriminative behavior that is happening more and more in our country, in our communities, in our hospitals, in our schools, and everywhere else, whether it be anti-Semitic, racial, immigrant, LGBTQ. And those isms change. When 9/11 happened, there was a great deal of hate directed at people who were perceived to be Muslim. When the pandemic occurred, there was a great deal of hate toward clinicians that were of Asian descent because people felt the pandemic had come from China. During the last election cycle, we saw a great deal of white supremacy hate and other kinds of things, anti-police hate, obviously, which has occurred because of numerous situations in this country. So we are now tracking that carefully and making sure that we are taking this very seriously, whether it be someone simply being called a name, whether it be a vandalism, whether it be someone who says, I don't want to be treated by this person because of blank. and that is not tolerated. Staffing issues, morale, and well-being are critically important. We have had a lot of people who are very exhausted from the pandemic, exhausted from the fact there isn't great staffing for many of our role groups right now. Recruitment is tough. People have left the field, people need time off, and that's hard when demand is so high. Compassion fatigue and the balancing of patient rights and our code of conduct. We now have a Mass General Brigham code of conduct, which simply states in a very public way in all of our main entrances what people may not do. They may not be abusive or speak badly or raise their voices or bring in contraband, et cetera, et cetera. That does not mean it's the end all be all. That does not mean people still don't behave badly and do the things we're asking them not to. But it means we have a complete way for caregivers to feel more security and empowerment of saying, we have this code of conduct, and telling every patient that. We've done a lot of work on staff safety versus patient care, so that there are times where staff people who felt very strongly that they needed to go into a patient room and get the job done, no matter how escalated the person was, and we've had to teach them that they may have to wait to get a blood draw or to do a test or to change a patient when the patient is escalating and their safety may be at risk. Longer lengths of stay. We've seen, dozens, if not hundreds of people waiting on gurneys in the hallways of our emergency departments. And for sometimes not only hours at a time, but sometimes days at a time. And that would escalate anyone, even the people of the most rational emotional being. I worry a lot about changing threats towards certain members of our healthcare communities, and I see this across the country. We've seen at Children's Hospital, caregivers and surgeons that were treating transgender health patients being targeted with death threats and other kinds of things, even if they weren't doing surgery on any juveniles. We worry about that at MGB, and we certainly worry about people who are doing women's reproductive health because of a lot of extremists who have been quite active in a violent way against people they perceive to be doing abortions. So I don't see that getting better. I see that worsening over the next several years, particularly during this election cycle. Recruitment and retention of security staff is harder because of the difficulty of the job, the extreme amount of violence that people are being subjected to, a lower pay than many other industries. We've had numerous people want to stay here and have been recruited by municipal police departments for much more money, or corporate security departments where they're not subjected to any kind of violence and for a lot more money. And that's hard. And we want people to look at this as a career path and really become entrenched with our environment. And that's so important. Next slide, please. Not a big surprise here. The aggressors of our incidents, for the most part, are patients, and the victims are mostly security personnel and nurses, nurses being the primary, but security actually leads the pack for having the most assaults and being victimized the most, because we're often the primary and the secondary once we get to aid a nurse or a physician or a front desk staff. What's interesting about this is when I started at Mass General several decades ago, I would say there was a 50%, there was an equal split between staff violence versus patient violence. And now it's about 95%, 5%. 95% are patient or visitor violence, and 5% has to do with staff. And I think we've gotten much better at our hiring practices and obviously having good people working in our environment. Next slide, please. Our mission at Mass General, just to give you an idea of the way we see our world, is to deliver protective and supportive services competently and to do it in a compassionate, empathic way, with welcoming, accessible, and safe environment. And nothing's easy with our outside services and our getting people into our hospitals and parking and public transportation and everything else. I'm very proud to say I think we have a team of amazingly compassionate, caring people that have been with us a long time, and that's true at many of the other hospitals as well. Next slide, please. We have a very robust workplace violence prevention program, and Jenn will be talking about it a little bit more. We have to have this because of regulations by Joint Commission, who is one of our major regulating bodies, and OSHA. And I'm proud to say we exceed all of these things, and we should, because there is not a one-stop answer for diminishing or reducing or mitigating workplace violence and conflict. It takes, it's a confluence of many factors. Next slide. These are the program highlights. The positive news is we're quite low compared to other hospitals our size and in our urban areas. We've done a lot of things that have helped to empower people and train people and have collaborative programs proactively. Jenn will describe some of these. Assaults on inpatient floors have been increasing a little bit. In the emergency department, they've been slightly decreasing. We're using a tool called a BRAT, which Jenn will explain that nursing uses to assess inpatients and emergency department patients regarding their risk for violence, and that's been very helpful. We all have a trauma-informed care focus and education, so all of our training for our security staff includes trauma-informed care. 98% of the time, we're able to de-escalate people who are escalating before anything has to happen, and that's very important, and we spend a lot of time in patients doing that. And you can see some things in the emergency department that we've done. We've done a deep dive into statistics to see where in the emergency department incidents have occurred, what time of day, what day of week, how long it takes for someone who presses a panic alarm to have security come. We've done a lot of things that really help us figure out how and where to deploy resources. And then our investigative team, Jenn, who you're going to hear from, heads that up. She is our senior manager of workplace violence and investigations. They do anywhere from 12 to 1,400 investigations a year, and that includes everything from extortion, fraud, theft, workplace violence, drug diversion, hate crimes, domestic violence, all kinds of things. And they works with the IS team on cyber events as well, and that's really helpful to have this small but very strong group. And we have, I think the thing I'm most proud of, and is the most, sometimes the least expensive, is really good training programs. And I see training as being part of everybody's job, just like hand hygiene would be. People need to go through training. It empowers them. It helps them understand what to expect. It helps them, the whole hospital in all of our hospitals, to de-escalate people. We have now a common training program that we use. We use it for HealthStream across all of the hospitals, and then inpatient training and scenario-based training and simulation training for those departments that need it. Next slide, please. This is an overview of our workplace violence structure. You don't need to read any of that, but there has to be an owner according to Joint Commission, which is obviously me. The teal boxes are our departments that are involved heavily with workplace violence. And it really does take a village. So patient care services, employee assistance program, patient advocacy, human resources, OC health, you can read the rest. Those are all major groups that have a vast involvement and focus on workplace violence and conflict. The oval blue shapes are the collaborative multidisciplinary groups. And again, we have a lot of work being done with a variety of people, whether it be psychiatric resources, chaplaincy resources, social services resources, legal resources, nursing resources, et cetera. And then some of the initiatives are in the gray boxes, and Jenn will be talking about a few of those. So at this point in time, I'm going to turn it over to her, and it's her birthday today. So she's spending her birthday with you all, and she'll talk a little bit more about this program in detail.
Thank you, Bonnie. I think we all know that workplace violence prevention isn't a singular approach or a one-size-fits-all. So we've developed proactive programs, responses, and resources to allow for a collaborative, multifaceted approach to preventing and mitigating workplace violence. With regard to overall security and safety, police and security have developed specialized teams to review new construction projects to determine vulnerabilities and subsequently recommend enhancements to the building and property plans. These specialized teams also review high-risk areas, and the recommendations may include, do we have the right access control in place? Is the area going to be open? Is it going to be locked down? Is video and intercom systems appropriate? Are there plentiful duress or panic buttons? Are they easily accessible? And camera coverage, is there enough? Is it widespread to cover any type of incident? And is it going to be available to review, not only for live, but to review after report of an incident? We do crime trending, looking at what types of incidences occur, the days of the week, time of the day, and that helps to determine where systems can and may need to be adjusted, and same with our resources. Our employees are introduced to our workplace violence prevention program upon hire. Our human resources department has extensive policies such as violence-free workplace, the no weapons. They've developed an extensive new hire training program and an in-depth harassment and reporting and investigative structure. As Bonnie had mentioned, Patient Care Services introduced the Aggressive Behavior Risk Assessment Tool, or ABRAT. This tool is used on a national level and requires the nurse to look at a patient's history and current behaviors and input a scale of 1 to 10. A score higher than 5 indicates high risk for an aggressive outburst within 24 hours. The implementation of this tool enables the nurse at the bedside to take an active role in engaging critical multidisciplinary resources, such as team huddles, which may include clinician, social workers, police and security, to discuss the behavior, requesting a threat assessment by police and security to determine the degree of risk an individual poses, and calling for a SMART team meeting. The SMART team is a multidisciplinary group coordinated by me that is urgently convened for complex and disruptive patients or patient families. On the slide, you can see a sample of one of the collaborative resources that we have created, a safety tip sheet that is placed in all staff work areas. And the tips use catchphrases such as own the door and buddy and cluster to remind staff to have an easy exit if things escalate with the patient. And if they're concerned about their safety and providing care, to take a colleague with them. For our patients and patient visitors, our workplace violence prevention program starts from the moment they enter our doors. As Bonnie had mentioned, we created, along with many other participants, the Code of Conduct, which outlines prohibited behavior. In short, MGH expects respectful behavior. This document is posted in our EDs, it's posted in our inpatient floors, ambulatory areas, and research. So it's quite visible. It is married to, I like to say, it is married to the Patient Bill of Rights to really foster that mutually respectful relationship between caregivers and patients. We started the Code of Conduct in the emergency department, and it, as I said, has since expanded throughout the hospital and across MGB. To sum up our proactive tools, we had a very difficult, aggressive patient in his early 20s who'd be dropped off whenever his mother couldn't manage him. I personally have a very big soft spot for this patient, really upon learning the amount of trauma he had experienced in his young life, and the fact that his adoptive parents did not use the resources that may have provided him a better quality of life. Staff who cared for him probably felt a bit, I know they felt a bit differently than I did. When he would come here, his behaviors included temper tantrums when his wants weren't immediately met, throwing items, furniture, though they were not directed at staff. His mother did not allow for comprehensive testing, so understanding his cognitive abilities was difficult. Due to his aggressive behavior, the patient has staff terrorized and would score above a 5 on the ABRAT. A threat assessment showed minimum law enforcement involvement, and those interactions were not violence related. After a couple of hospital visits with these scary outbursts, the SMART team was engaged. We consulted with our autism navigator, who met with the patient to try to get an understanding of his intellectual disabilities. And the SMART team was able to put together proactive interventions to mitigate triggers to his aggressions. such as when he came in, to move him to a quiet area or a private room as quickly as possible, music therapy, having snacks available, and conversation topics that he would respond to and engage in. In addition, the SMART team enlisted the assistance of outside agencies to offer additional supports, mental health services, group and day programs to keep him engaged and less violent. Subsequently, his stays with us have become much less frequent and a whole lot easier. Next slide. So while proactive measures are incredibly important, they do not negate the need for reactive responses. As you can see, we've broken our reactive responses into several categories. It may be an in the moment or emergency response, a violent patient or visitor. Staff can press the duress or panic button, and police and security will respond immediately and in force. If staff feel that a patient or visitor may have a weapon on them, they contact police and security, and we'll address the concern with the patient or visitor in a discreet, professional manner. When advance notice is provided, we might conduct a threat assessment and encourage a discreet standby to ensure a meeting or an appointment goes smoothly, or to be able to quickly intervene and address the behavior in real time. Bonnie mentioned my investigative unit. In addition to our individual cases, we also determine risk through intelligence gathering, assessment, and analysis to ensure we're aware of activity or events in the area which could have a negative impact on a community, such as the gender affirming care protest. We've developed many federal, state, and local relationships with law enforcement and security organizations to share this information, as we all know that being prepared and having the knowledge allows planning to mitigate the threats against individuals and our community. Investigations are often completed with recommendations for process improvements to help prevent reoccurrences. In-depth, customized safety planning is often conducted for patients that are at risk or may pose a risk to the institution, such as gang members brought in after a violent episode, public figures, as well as domestic violence survivors. We have a robust, collaborative, disruptive patient committee, which meets monthly to review every single report that has been filed on a patient involving violence. One of the outcomes of this group that I think is a best practice is the safety, security, risk icon or flag. The icon, you can see a sample on the slide. The icon is displayed within the individual's medical record, and it pops up and gives an alert when that patient registers or comes in for an appointment. And it alerts staff to the immediate concerns for violence and recommendations to mitigate those concerns. The icon also connects with the acute care plan that will give a much more in-depth review of concerns, behaviors, and the plans and interventions that we have put in place to, again, address those concerns. I think it's really important to note that the icon is not to label or profile a patient, but rather it's really to ensure that staff are safe while they provide optimum care to the patient. This collaborative group continually reassesses the patients with the flag to ensure that there remains a need, and all of our interventions and resources are carefully thought out and developed to ensure a DEI and trauma-informed care lens. To paint a picture of our reactive resources, we had an employee who was a survivor of domestic violence. She had not disclosed this history with police and security, our employee assistance program, or her management team. So one day, a duress alarm came in for her area, and upon arrival, she advised us that she had been in an abusive relationship, and although the relationship was ended, the individual was present to see her. That individual was escorted off property and issued a trespass that prevented him from coming back unless for emergent treatment. We did a threat assessment on the individual that showed minimum law enforcement review, but also showed that he had no registered firearms and no license for a firearm. We are able then to work with the employee and an advocate from our employee assistance program to work on a good customized safety plan. For this employee, that included temporary parking, escorts to and from her vehicle, reviewing her home safety measures, and we escorted her to court when she was ready to obtain a restraining order and stayed with her through subsequent court appearances. The reactive resources help that are available help not only keep our environment safe, but ensure our employees, patients, and patient visitors know that their safety and security is an organizational priority. Next slide. For any program to be successful, we continually have to evaluate it. We do this through reconciliation of incidents reported to our quality and safety group and to police and security. And we ensure there are no gaps between the two. And we also ensure that appropriate follow-up is done without duplicating efforts. Record-keeping documentation is critical for having legitimate metrics. These metrics build and support the arguments for education, resources, along with staff deployment or reallocation. The information that we gather from our internal record management systems, as well as our national data, not only validates existing programs, but will support the need to implement new services. Employee wellness remains at the top for measuring our success. Do employees feel safe? Do they feel supported? Do we follow up with them to ensure the employee is aware of the multitude of resources available? Working together, we have streamlined the accessing of resources for employees, and we have formalized our documentation of follow-ups. We are very proud of the work that's been completed by a lot of great teams and are confident that the array of services, resources, and tools provided are paramount to employee satisfaction and feeling safe at work. Bonnie, Matt, is there anything that you want to add to that?
Thank you, Jen. And just going back to the last slide where Jen talked about specific customized safety planning, we have about 24 people a week that may need to be what we call off scope or not able to have visitors or not want anyone to know where they're at. And it could be for protection of gang members. It could be people who are in the public eye. It could be people that are in domestic violence victims. There's all kinds of reasons. It could be employees that would just like to remain anonymous. But the one compelling case I'll never forget, because we never know what the reason is someone wants to be not able to be found, if you would, was a case of an older woman many years ago who came in with advanced metastatic breast cancer. She told us she absolutely was terrified that her husband would find out where she was at, and we needed to protect her and make sure that nobody knew that she was in the hospital. And when we asked her why, we said, "Are you in fear of your husband?" Assuming that was the case, she smiled and she said, "Oh no, he's the love of my life. We've been married 60 years. When we looked at her quizzically and said, "Then why do you not want him to know where you are?" She smiled and she said, "We're Christian scientists. We don't believe in Western medicine. And if he or other family members were to know where I was at, they would have to take me out of the hospital. And I've decided I want this treatment. So that's why I need to be anonymous." It was so sad. I remember it made me cry, but you never ever know what people need, and these services have to be customized. Jen, thank you. Matt Thomas is our senior training specialist. He's been here a long time also. Does unbelievable things with a training of hospital employees and our own department, and simulated training with our residents and physicians. Matt, I'm going to let you talk a little about training, if you would.
Thank you very much, Bonnie and Jen. And I appreciate everyone taking the time and allowing me to have the time today. Training, it's what I do. And the way I look at it is, if you follow me for a second, what we don't know, we don't know. So in order for us to know, someone's got to present it to us. And, you know, we don't learn through osmosis. So training and education is the way to go. Here at Mass General, we have built a very robust training program, which I'm going to talk a bit about, and then do some specific training with you for a limited time, so you kind of get the gist of exactly where it is that we're going, and an example of what we do. Our overall goal is to decrease violence, and in order to do that, we have to populate your, as I call it, your well. The well is the, if you don't know, you don't know, the empty piece, where if you have a bad situation occur, when your brain goes to the well for information and response, if there's nothing there, you freeze. That's the way our bodies react, as opposed to being able to physically defend yourself or to escape a bad situation. So how we do that is we provide numerous training programs, majority of which are to prevent workplace violence, but others involve property like identity theft and computer crimes and cyber and stuff like that. We have 4 different categories, I guess you could say, that we classify our training, and the more you learn, the safer you're going to be. So when it comes to our major training programs, these are built based on circumstances of more acute situations. So most of it's related to workplace violence. And, these are given in person and hands-on. Those go together, and either in virtually, but very interactive. Clearly, we would prefer to be up front and up close and personal with folks. It's a better learning experience. We've found over the years that, clearly people learn better when you're face to face. All our training programs are customizable. So we work with other units, our floors, our healthcare centers, our, anybody throughout, not only just Mass General, but, the MGB system, to develop programs that are specific to their locations and what they do. So it's a value to them. One example is that recently we have had a high demand for phone de-escalation from our call centers and from our front end managers, where their staff, though they may not interact face to face with folks, they're on the phone, and people are just as angry on the phone as they are if they're face to face with you. So we were able to develop some specific programs using our Evade Workplace Violence Prevention Training Program, which I'm going to touch a little bit more on in a minute. But we're able to take principles from there, specific to de-escalation, and more specific to phone de-escalation, to provide very valuable training for them. And it's more worthwhile to them because it hits closer to home, and that's really important for them. In terms of the electronic, genre, we have published several electronic trainings that we host through Mass General Brigham in our health stream learning management system. And those are basically on demand. And what happens with those is either managers assign them to their folks because they feel they're valuable, or folks that are looking for more information and looking to learn more about security related topics can go on there and basically self-enroll in those programs. Lastly, we offer other training programs. That's like the catch-all, right? If you want to learn about it, and it has to do with safety and security and stuff that we do, then we want to be the ones to teach you about it. And it's important to us. And whether we have presentations or training that are already developed, or it's a topic that we don't talk much about, but we can develop it, that's what we do. That's what we do, because our main focus is to reduce violence, reduce crime in general. And to be able to do that, we've got to provide as many services, in this case, training education programs, as we can. And I pride myself in what I do, but also what our department does and the support that we have in trying to educate folks throughout the system. So as you can see, we offer in-person training, we offer virtual training, and we offer electronic training. Clearly, the most valuable is the in-person training, because again, like I said before, we want to get out in front of people. We can do more hands-on work. We can practice more mental conditioning. We can practice more physical work, where, not only is our brain working with our body, vice versa, but we're learning things, putting things in that well that may not have been in existence before. So that way, again, in case bad things happen, we're in a position where we're not going to freeze. We're going to take positive action for our safety, because our safety is number one. So to talk specifically about one of our training programs, our Evade Workplace Violence Training Program is a program that, we went to, say within the last couple of years, but has now gone Mass General Brigham wide. And that's a huge thing. But to give you a flavor of, this training, I want to kind of walk you through it a little bit. And Evade, it's highly proactive. It's extremely effective. And it is, it teaches good skills and habits on how to prevent, avoid, de-escalate, and mitigate workplace violence, violence in the workplace, conflict in the workplace, which is really, really important. AVAID is an acronym like everything else we do in healthcare. We have acronyms for everything. It stands for awareness, vigilance, avoidance, defense, and escape. Those are the principles that make up the AVAID training system. And if you think of it from from a hospital system, you have Mass General Brigham, which is the company, which is the corporate entity. And then you've got healthcare centers, hospitals, research facilities, schools. Those are the principles that make up the system and makes the system stronger. So when you take pieces of awareness, vigilance, avoidance, defense, and escape, and you cluster those together, you become safer. Okay. So first things first, I'm going to kind of walk you through this a little bit in the time that I have. Who's in charge of your safety? I ask everyone that when I teach a class, whether it's online, whether it's in person. And the answer clearly is point at yourself, look in the mirror. You are in charge of your safety, because when bad things happen in that moment, you need to be able to stay safe until help arrives or until that situation is resolved. So we're in charge of our safety. We want to empower our folks, our students, to take control of that and to own that. That's really, really important to us. And it's really, really important for them. From a patient care perspective, if we're to provide treatment for patients and we are scared or we feel unsafe, well, we can't provide that treatment. If a patient is escalated or escalating, we need to de-escalate in order to provide that care. So we go from a treatment perspective to a de-escalation perspective. Okay, so let's take a walk through of AVAID. First thing, awareness. Okay, so think about awareness from a couple different perspectives. First off, self-awareness. We have to know ourselves. We have to know if we're physically okay, if we have anything we need to compensate for if bad things were to happen. We also need to know ourselves emotionally, because our affect and the way we work with people and the way we project ourselves on other folks is going to have an impact, either positively or negatively. Emotionally, and other folks, same holds true. We need to find out, through observation and interaction, how our folks, these people that we're working with, are feeling at that moment, because that will help in terms of how we interact with them. Situational awareness is always going to be one of the bigger things, because if an incident, say an aggressive person is occurring, and our response is that we de-escalate effectively, then the outcome of that situation is going to be positive. And we're always looking for positive outcomes. When it comes to environmental awareness, are there things in our environment that may harm us should something go bad? Now, I'm not trying to vilify everyone, but if we have indication that things are escalating or have escalated in the past, then we need to be safe. We need to be careful for ourselves. So when we go to a room, we need to figure out exactly what is present in that location that could harm us. So everybody humor me, okay? Everybody close your eyes. Seriously, close your eyes. Don't worry about the pickpocket sitting next to you. Anyway, so I want you to picture this. You walk to the threshold of a doorway. Say it's a patient room. And if you don't, and I'm not familiar, we can pretend, because mental conditioning, whether it's true or not, is going to help us work through this. So you walk to the door of the room, and before you go in, you assess yourself. Physically, I feel good. Mentally, I'm good. If you're having a bad day, you got to put it in your back pocket. Happiness and positivity are contagious. We need to reflect that on our patients. Okay. So before we knock and introduce ourselves, we're going to look in the room. We're going to see what's happening with that person, with that patient. They're pacing back and forth. They're pumping their fists. They're red in the face. They're rolling their neck like they're trying to, crack their neck like some people do. And then you look in your environment. Not only where is the patient in the room, the fact they're pacing back and forth, but what else is there? You look on the table next to the bed, and there's a steaming cup of coffee. And the two crutches, for some reason, your patient's not using them right now, but they're both standing up close to that patient next to the bed. Well, these are all things that we need to educate ourselves on, and we need to become aware of, because if bad things happen, all of that is going to come into play in terms of what happens going forward. Okay. So the second thing we're going to talk about is vigilance. Now that we have become aware, we need to trust in our feelings. Do we have a sixth sense? Would we call it intuition? Well, clearly, I think the answer to both is yes. We have to trust our gut. We have to trust the hair that stands up on the back of our neck. We have to trust the butterflies that go off. We have to trust the fact that when we walk to the threshold of a doorway and we observe someone who is agitated, we need to trust our assessment of that. Okay. If we don't, bad things could happen. So we need to be vigilant about our awareness. Think about that same scenario that you just pictured in your mind. Okay. Now, with all that's going on, you have two options. You either enter into that situation, you walk in the room and you have an interaction, you roll the dice essentially, or you take a step back, you get more heads involved, and you try to figure out a better plan to interact with that patient. And maybe nothing happened and nothing happens. That's great. But I don't want to take the chance. I want to get more people involved. I want to be more educated when it comes to that interaction so I can keep myself safe. When it comes to avoidance, this is the most important piece. We all have to agree that if we can avoid conflict and aggression, we're going to be way better off. We could do our jobs, but even beyond that, where our safety is number one, we're going home. And that's really, really important. So when it comes to, avoidance and different things, we work through trauma-informed care. We have to recognize that everyone's got a backpack and it's trauma, whether it's something that they've experienced personally or third hand. We don't want to re-traumatize them. We want to work together as a team. We want to make the experience better for them. We talk about implicit bias. We have to check ourselves at the door. We've all been exposed to some type of stereotype in the past, and we need to understand that that may be in existence. But we have to treat people based on their behavior when it comes to prevention, because if it's anything else that gets involved, then it negates the problem. It negates the fact that we're there. It exacerbates the situation. Okay. I've worked over my 24 years at MGH with a lot of folks who are homeless, and I've had great interactions and I've had bad interactions. Now, if I'm responding to a call where I'm going to work with someone who is homeless, and I go in there with that chip on my shoulder and thinking that this situation is going to go sideways, does that affect the way that I interact? I say yes. So we have to check ourselves. We also have to be aware that our behaviors, not just what we say, how we interact with folks, is going to have an effect either positively or negatively in every situation. Now, we don't come to work to cause problems for people, to create escalation. However, sometimes we do it inadvertently. We need to be aware of that. We need to make sure we take proper steps. We talk about behaviors too. I'm not going to get into this in particular, but we talk about folks who are anxious. We talk about folks who are angry. We talk about folks that become physically aggressive. And there are ways that we can see these behaviors evolve, and things that we can do where we can be supportive or we can be assertive. And if necessary, we can become defensive.
Matt, you need to wrap up in about a minute.
You got it, no problem. When it comes to defense, clear and plain and simple. We have a longer class for this, so I can't get too much into it. However, you need to get something in the way. You need to protect yourself. You have every right to defend yourself if something becomes physical. So please do. Best defense, don't be there. Don't be there. Don't get off the tracks. We say when the train is coming, so that way you're not in the line when somebody comes to potentially do you harm. Try to get away, which leads to the last thing, which is escape. If you feel unsafe for any reason, get out, escape, disengage, create space, call it what you will. It doesn't have to be pretty. It just has to be effective. Know where your escape routes are. Don't get too close to people, because the closer you get, the more vulnerable you are. Own the door. Stay close to the door between you and the person you're concerned about, and you're going to be way better off. Nothing's 100%. Nothing's foolproof, but you'll be way better off. You'll be safer if you implement some of these different things. So that's kind of a quick go through when it comes to our workplace violence prevention program. Thank you again for your time. I'm going to hand it back over to Bonnie.
Thank you, Matt, very much. To conclude, because I want to give a few minutes for questions. We've tried to answer some. This isn't a perfect science. There is no perfect science. We don't talk about zero tolerance for workplace conflict or violence. We talk about zero ignorance for it. Because what we think about is how to ensure we've got the foreseeable situations under control. And most of what we deal with is foreseeable, but there is always the unforeseeable, as you know. It's also important that we keep people's fear level, staff fear level in check, and be able to do what they need to do to feel safe. We do not ever want to see people leave our employment in any role group because they're not feeling safe. That's a huge cost to our institutions, but more importantly to everyone's morale. And we've been, I think, very fortunate around that. We need to balance patient care and patient safety along with staff safety. And that's a difficult and challenging balance. We need to ensure that recruitment and retention for all of our role groups are creative and continue. In security, we have made massive efforts and achievements in having more diverse workforces, people that are experienced, educated, compassionate, but from lots of different backgrounds, with lots of different languages spoken, etc. There were questions in the chat about the code of conduct. How do we enforce it? We enforce it by allowing all of our caregivers on our units to say that this is necessary, and that if people fail to comply with the code of conduct, they may or will be asked to leave or may not receive medical care. If it escalates from there, obviously security can be called. There are times, however, I'd be not telling you the truth if I didn't say there are times that when someone can't leave because they're medically too infirm to leave, that we can do something about the way they're behaving. If they're yelling inappropriate comments or words, or swearing or screaming, or putting others at risk, and we do the very best we can. We keep a DE&I focus as well at all times, and we're really vastly looking at our statistics around that and making sure the right people are getting those reports, and that we're making inroads into ensuring that people understand that they cannot behave in ways that are disrespectful to any member of our care team. We're hoping, I saw a question in the chat, which was great. We're hoping to engage our physician groups more. Physician groups are trained, but I don't think many of them have had the in-person training. And we found, particularly in the emergency departments, where physicians have been trained with other role groups, it's very effective. We've also seen in general, not just with physicians, but with everyone, a definitely statistically significant correlation between those people that have had in-person, whether it was MOAB previously to evade, and evade training in person, where people have learned what they're doing to perhaps escalate people, and what stage of conflict someone's in, and what to do at every stage of conflict, that those people are not being victimized or not being injured, etc. There's definite clarity around that, and we're continuing to work on that. I would say, as the last paragraph says, this is always a work in progress. And it evolves, and we need leadership support, which we have. We need a lot of employee buy-in. We need really good policies and procedures. And we need a lot of care and patience and thoughtfulness around acute care plans for patients, around medication plans, around what people really need. It really does take a village. So I know we only have 9 minutes left, so I want to stop at this point and thank you again for being here today, and for allowing us this time to share some of our world with you and what we're trying to do to be a great asset to our hospitals. Thank you.
Thank you so much, all of you. This is really it's such an important topic, and you can see by all of the activity in the chat and in the Q&A that it's really resonating with people. You know, what I'm sensing is that people really have this sort of conflict between understanding that often it's traumatized people who then, you know, display behaviors that may be traumatic to others. And I think that's what people are, you can see it sort of threading through the comments in the chat and in the Q&A, that sort of inner conflict. But I let me read you some. You've addressed a lot, so thank you for that. There are some here, again, you know, more questions about how you understand or come to understand what behaviors on the part of staff, or, you know, attitudes or behaviors can sometimes trigger aggressive patient behavior, and how you identify that, classify that, inform, follow up, and so forth.
I think the best part of was previously our MOAB program, management of aggressive behavior, and now our evade program, which is kind of MOAB on steroids, I think addresses this beautifully. It teaches people what we all do when we don't even realize, with our stance, with the way we stand, with our space from people, with our eye communications, with our facial expressions, with our body expressions. I mean, so much of important communication, what people hear is not what you say. What they hear is your nonverbal communication. Oftentimes, it teaches people tone of voice, rate of speech. It's called paralanguage, and how we sometimes raise our paralanguage, our tone of voice, rate of speech, volume of speech, when someone's getting escalated, and how that is the worst thing we could do. So how to teach people not to do that, because what we all want to do is de-escalate people, but what we don't know sometimes we're doing, because we haven't learned some important techniques, is we are escalating them. So those are just a few examples of what we do.
Bunny, can you also address what you do for staff in the aftermath of some kind of an incident or a violent event? How do you support them?
Yeah, I think that's different at different hospitals, but everyone who is a victim of, it doesn't have to be an assault. It can be an attempted assault. It can be an extremely threatening or scary situation that did not result in an assault, gets a follow-up, and they get follow-up from their own management team. They get offered EAP. They get follow-up from police and security from us a day or two later to see if they need anything, to see if they need any special services of any sort, even if it's just they'd like to be, escorted to their car or to the MBTA for a while. So everybody gets a lot of follow-up. And I think, frankly, that hasn't always been the case. And that's gotten much better from, again, a myriad of departments around the hospital that have now understood that employee wellness means that post-incident responsiveness and follow-up is critically important.
Absolutely. I'm going to read through some more of these. Let me get out of the Q&A. I would like to read you a little bit more here. This is really important. Can you talk about a care plan for an aggressive patient on a unit for weeks, waiting to go to, awaiting placement in some kind of other facility? That is such an issue right now.
Jen, I'm going to let you take that one because you do it a lot when you head up these SMART team meetings.
Can you say what SMART is too, what that stands for? Strategic
Management Assessment and Response Team. It's just a multidisciplinary group that gets together with the right relevant people to look at prior to a situation occurring, sometimes right after, but often it's proactive when there's a really complicated case somewhere with a patient, usually a patient, but sometimes a visitor. But Jen, I'll let you take this.
Okay. So, the care plans are very customized to the exact behaviors exhibited. So I'm going to try to talk a little bit more broadly and just give an example. So a care plan might be, say, a patient, and we certainly understand we have patients who are here for months at a time that are aggressive assaultive, but we're going to, look at medication interventions. Are there social services? Are there, our autism navigator, our PT and OT departments are great about working with a patient, working with the SMART team on finding distraction methods. So when a patient is starting to get agitated, what can be done to distract? Depending upon the level of violence, sometimes a veil bed is recommended. We've had extreme circumstances with patients who've been long term, where almost essentially everything has been moved out of the room due to the outburst. We will reach out to other agencies such as Department of Mental Health, if that individual is a client of theirs, to see what responsibility and what assistance they can do. We keep our risk management team and our Office of General Counsel involved to ensure that there aren't any liability concerns. When you determine a patient no longer is here for medical treatment and they need to be discharged, even though they might not want to be discharged, sometimes we've had to work with our general counsel on managing that. But the acute care plans really will go into the weeds, so to speak, with details. Early intervention from police and security. If you're going to provide care, police and security will come up and do a standby. In extreme cases, do we need to look at a detail person on that patient to protect staff? You can't stress enough, the goals of any of these acute care plans are really to benefit the patient and keeping staff safe. So it is no one is sacrificed for the other. It's really working together to find out whatever will keep a patient calm or help that patient get discharged to a more appropriate setting. I'm sure no one else has the difficulty of moving a patient to, either a state hospital or to a skilled nursing facility. So I apologize, I get a little passionate about this, but certainly I can talk about this offline too.
Thank you so much.
And any of the things that we've talked about today, please feel free to call any of us for further information or suggestions or any advice you may need or want at any time.
Thank you so very, very much. This is really an incredibly important webinar, an important topic. We really appreciate your being here, your expertise, and your presentation. Presentation will be on our website in a period of time. Angelina will talk some more about that. So you will have access to listen to it again, and you'll be able to review the slides and so forth. So I'm going to thank our panelists once again for a fantastic, informative presentation, and turn this back to you, Angelina.
Thank you so much to our panelists and Dr. Lown, and thank you for everyone who joined us today. We hope you enjoyed this webinar. Please keep an eye out on your email for future webinars and events. And please take a moment to fill out the brief survey that we'll be sending you after the webinar. We really appreciate your feedback on today's session. Thank you for joining us and for your commitment to compassionate healthcare. Take care, and we hope to see you soon.